So we'll move on to the next session, which is vascular disorders of the retina. And I'd like to welcome Dr. Sharad Gumad, sir, who will be chairing and who will be co-chairing the session. We have the first talk by Dr. VIRCON, Mr., but he's not. He has a little bit of difficulty connecting right now. Am I audible?
Hello, Piyush. Piyush.
Good afternoon, sir. Thank you so much for joining in, sir.
Yeah, Piyush,
we have Dr. Natarajan, sir.
Yeah, Piyush, I have a request. Hello. Can you hear?
Please, sir.
Yes, we are able to hear you.
Nothing.
Yes,
no,
we can hear you, sir.
One of my close friend actually died and I'm coming. So I thought I'll finish my talk and go. And you
yes, sir. Please, sir.
Okay. Sorry for the...
So may I invite Dr. Natarajan, sir, to please give his talk on screening to surgery in diabetic retinopathy.
Yes.
So like we all know, Dr. Natarajan has really taken diabetic retinopathy screening to a whole different level. And as AI's past president, he ensured that there were a lot of screenings that were done all throughout the country, especially our state. It's a topic that is very close to him. And so we can't see your screen yet, sir.
Yeah, well, 1 second. I'm just thought I think the desktop something is wrong. 1 second.
Sure, sir.
Now you can see the screening, the screen.
Yes, sir. You can see it.
Okay. Yeah. So preventing a proliferative diabetic retinopathy blindness from screening to surgery. So there is no financial interest to disclose. So I made this program, as Dr. Piyush mentioned, as an All India President, screening through teleophthalmology to prevent diabetic blindness, and we called it Jot Se Jot Jalao. So the global prevalence, it's going to diabetes keep increasing, and we have 77 million diabetics in India, and by 2030 it will become 101, and by 2045 it will become 134.2 million. So all of us have to be wiser so that we recommend primary checkup at the time of diagnosis in every patient with diabetes, and prevention is better than cure. So we have this plan of action: screen, diagnose, and treat. So the process flow is to have a pre-camp awareness, and I think everybody and anybody should do. That means doctors, optometrist, diabetologist, physician, IMA members, maybe even Ayurvedic. Everybody should do at least a screening, assembly of diabetics, capturing of images, uploading, and diagnosis by ophthalmologist or using the AI. So we have a problem in the health system: one ophthalmologist per 100,000 population, low awareness or ignorance, and 70% of Indian population resides in rural area or urban slums. And the technical difficulties are unreliable internet coverage, deficit in supply of electricity in many areas, shortage of trained medical staff for operating conventional fundus cameras, and portability of conventional fundus camera. And here we are using role of artificial intelligence, and I like to define intelligence is the capacity to analyze, think, make a decision, and categorize. And artificial intelligence involves formulating a specially made algorithm according to our needs to develop this capacity and include it in an electronic device like smartphones. So this is a best thing available. As I said, no financial interest. This is made by Remedio, and it's an iPhone attached to a infrared device, can be mounted on a suitable bike for transporting for screening purpose, can be mounted on any table. It is chargeable. And then I call this as anybody can screen for diabetic retinopathy. What I mean by this is I've trained my room boys, the community health workers who are only seventh pass or fail, who can handle the mobile phone and the infrared device and take pictures and send it and you can see this is the video which shows anybody can focus and take a photograph. You can use 1% tropicamide and then focus and take a picture and then apply it to AI, and then the AI will say which is a referable diabetic retinopathy or which is a software is called Meteos, made by a company from Singapore. Again, I don't have any. This blue, what you see is the one which picks up the lesions and then says referable, and no need to refer for diabetic retinopathy. That means at the spot within 30 seconds, the person can find out whether you need a referral or not. And then simultaneously, the same images can be posted to the main place where the ophthalmologist can check it up later, and then there's no emergency, so the person can check. And this is a comparison on fundus phone with the size, and this is a AI with the blue one which picks up the lesions. And then so this is again how we can make the diagnosis. So we also did a study: is artificial intelligence reliable to pick out those in need for seeing an ophthalmologist? So we published the results in JAMA Ophthalmology as an original investigation: diagnostic accuracy of community-based diabetic retinopathy screening with an offline artificial intelligence system on a smartphone. I'm happy this was quoted in the American Academy as the future of diabetic retinopathy screening, but I'm happy to say we are already using. This is the first of its kind in the world, and we are ahead of Google use of offline AI for screening for diabetic retinopathy, using a non-skilled worker, train them only for this and make them a semi-skilled worker in the Municipal Corporation of Greater Mumbai Dispensary by the Aditya Foundation. The pilot study, we did 231 out of 255 patients considered for prediction of referable diabetic retinopathy using AI. And we did a field trial. The average diabetes was about 5.5 years. Patients with no diabetic retinopathy, 187 according to ophthalmologists. And AI found 172 patients with no diabetic retinopathy, which means 8% were overdiagnosed by AI. And this was the most viewed within a month, most talked about article of 2019. It was in the top 5. And reliability of AI for screening population for diabetic retinopathy in need of ophthalmic checkup by eye doctors 100%. And then advantage of using AI: early referral of referable diabetic retinopathy, greater awareness about diabetes, its effects and importance of regular follow-up, greater chat time to referable diabetic retinopathy, timely medical surgical intervention to prevent complete loss of vision, and more job opportunities, more working hands, skill development of less educated. This is our NGO, the name given by the former president, and he inaugurated the van. And I have the best friend, Mr. Shivanand. And this is the first one in the project in carrying Forus 3-netra camera in a motorbike, which was inaugurated by my grandmother, my late father, and Shivanandan and Ravichandran. So I do, in case, in spite of the screening and the patient comes very late, we do the when to operate, site-threatening traction retinal detachment, non-clearing vitreous hemorrhage, combined traction and recmotogen retinal detachment, taut posterior hyaloid, rubeus iridis with the vitreous hemorrhage, and vitreous surgery, which surgical objective is to thorough removal of the vitreous bleed, endolaser for the non-perfusion areas, reattachment of the macula, removal of traction. So the whole idea is to restore, maintain vision. So this is a 48-year-old with bilateral vitreous hemorrhage, and you can see I'm using the 23 gauge vitrectomy, 3/4 Pascal vitrectomy. The patient had a visual acuity improved from counting finger to 618, and both I had similar picture at present performing the anterior vitrectomy, then the posterior vitrectomy, and you can see the fibrous tissue arising from the optic disc into the vitreous cavity. So anteroposterior traction and all the is relieved, and also the transverse traction is relieved only with a cutter. And then I actually do a diathermy, and after the diathermy, I do this cutting out the fibrovascular stalk. But in spite of that, you can see it will bleed. Now I'm doing the diathermy, endodiathermy, and then after the endodiathermy, I do the using the cutter. I cut the stalk, but I can see that still it bleeds. So we can instead of increasing the intraocular the pressure, I always do a diathermy. I don't like to raise the intraocular pressure because the optic disc can be compromised, and already in a diabetic, the optic disc is pale. But I think best is to do a good diathermy and then do the control the bleeding. And then I use the cutter. You can see the entire retina. Then again, to do a pan-retinal photocoagulation, you see, except the optic disc and the and then I do a fluid air exchange using the retinal brush, and then complete with a non-expansional gas mixture. And then this is a proliferative diabetic with the traction retinal attachment with the visual acuity of 2/60 pre-op, and you can see I'm using the proportional mode. I'm using the 25 gauge 3-port pars plana vitrectomy. I'm glad I introduced the minimal invasive vitreous surgery along with Mark Kumar, and the man who made the artificial retina first in India in 2004. So we have also used 27, but I think it's unnecessary, adds the cost. So in 25, you see here, I cleared the pre-retinal vitreous hemorrhage using the cutter only. With minutes, or 1 minute. So this is you can see I use the proportional mode where I push the fluid between the fibrous tissue and the retina, and then thereby we can make a cleavage and then clear of the entire fibrovascular proliferation, as you see here, and complete the pan-retinal photocoagulation, and followed by a non-expansional mixture. And then this is the postoperative visual acuity 6/9. You see the optic display, the same eye. And this is a combined traction retinal attachment. We do the cataract, and then we also do the intraocular lens. And then you can see the PFCL was used. And then finally, remove the traction between the optic disc and the brake. And then I do the laser around the brake and complete the do a pan-retinal photocoagulation, fluid air exchange. And then you can see a cataract, vitrectomy, buckle, endo laser and gas, everything so this is a twin light vitrectomy, which we use it using the it's a dark one with a 20, and here you see by both hands can be used, catch the fibrous tissue, and then use the cutter in between and remove all the traction. The aim is to have a no iatrogenic break. Once upon a time it was 20%, and now we want to reduce it to as low as possible an iatrogenic break. So the whole tissue is cleared, and then the pre-retinal hemorrhage is cleared, pan-retinal photocoagulation is done. So this is I use 3D fantasy vitreous surgery, and all the time I do that. And then the benefits are you can everybody can see what you are doing, and then this is the setup I use, and then whatever I'm seeing, the entire operation theater can see. And then this is the one again I'm actually skipping. Thank you very much for the opportunity to give a talk. And if any questions, I'd like to answer.
Thank you very much, sir, for this lucid presentation, right from screening and then going on to those fantastic videos. I think you've covered pretty much the variety of diabetic vitrectomies that we get to see in our usual practice, yes, and some really nice pointers that you could give us. Do we have any questions from anybody that we can ask, sir?
I can see Manoj is there.
Yes, sir. What is the twin light? I am seeing something new today.
Actually, twin light was done when I bought it in '95, I think, from Class A card, made by. So now what I do is, it is like a 2 elimination like this into the vitreous cavity. So that there is no shadow, if you have seen. So it eliminates the entire vitreous cavity very well. And it's actually like a 25 gauge 2 light sources, which you can do with the 2 Paul Tornambes light source also.
Okay.
This was designed by Eckhart and made by this one. So I have the old video, and after a long time I started using it recently, and I think I should put the new video. And
we presented a video in 2005, new Retina, sir.
That's correct. Same thing.
Same video, twin light user.
I think the second case I escaped today, and I think even Nazimul was there once, I think, the OT that time. Anyway, I like to buy all these toys all the time. My second mentor was not happy to buy new instruments, but I always want to do the newer things all the time.
Yeah, that's good. Thank you, sir.
Thank you. So, Piyush, I'll ask. I think Dharmesh, you know Dr. Vasudev Ginde, you remember him?
Yes, sir.
No, unfortunately, he passed away early morning. So I
Oh,
just came there for
sorry.
that. That's why
Oh,
they excuse me. So I'm going there to the house. Okay.
So thank you so much, sir, for still giving us the time, and our deepest condolences.
Yes, thank you.
So with that, we move on to our next speaker. If Dr. Sarang is there, Dr. Sarang, are you there? Dr. Sarang Lambat? Okay, perhaps Dr. Devendra Venkatramani?
Hi, Piyush. I'm here.
Hi, Devendra.
Very well,
Excellent.
thanks.
We'll just we've got a major reshuffle going on right now. So from diabetic retinopathy, if you're ready with your presentation, Dr. Devendra, then we can
Sure.
perhaps start yours. Perfect. Very nice of you. So Dr. Devendra Venkatramani is, like we all know, a very dynamic retinal surgeon practicing in Navi Mumbai and Pune, and he shall be speaking on how AMD treatment has evolved.
So thanks,
Over
Piyush.
to you, Dr. Devendra.
Thanks, Piyush. It's a pleasure to be part of this August meeting as well as this lovely session. And I'll just clarify the topic a little bit. It's more how it has evolved in the last 1 year. And 2020, when it dawned, I distinctly recall all of these forwards on WhatsApp wishing ophthalmologists one to another that it's the year for ophthalmology, because now this is we hope that all our patients will get 20/20 vision. And it was a year full of positive expectation. And then it ended up being the pandemic that is going to define hopefully the rest of our lives, and no more pandemics after this. But it also marked an important watershed, because this was the year in which brolucizumab was launched, and there's a lot of hype and buzz and interest about this molecule. So let's see how practice has changed with the introduction of this molecule. So just to give a little bit of an overview about fluid and neovascular AMD, we all know that fluid is the most important aspect of treatment and also retreatment of patients with neovascular AMD. And fluid can be in different compartments, whether it's subretinal, intraretinal, or sub-RPE. And these were findings from the CAT study, which showed that sub-retinal fluid was the most common, followed by intraretinal, and sub-RPE the least. But whatever kind of fluid, all the guidelines suggest that we really need to dry the retina as best as we can, whether it's the EURetina guidelines, the Royal College of Ophthalmologists guidelines, or the American Academy of Ophthalmology. And all of these are OCT-based guidelines that talk about retreatment on the basis of fluid persistence. All retinal fluid is considered pathological, but as of now, we really don't treat sub-RPE fluid, although it may be an early sign of disease activity. It's more or less our treatment and retreatment is restricted to the presence of intraretinal or subretinal fluid. Now, the Hawk and Harrier, which were the two pivotal trials that examined the role of brolucizumab versus aflibercept in neovascular AMD, showed these very interesting findings. If you can look at these graphs and try to make sense of them, you can see that the best corrected visual acuity is much poorer in those patients who had high disease activity, which was defined as the presence of intraretinal and or subretinal fluid at those various time points. So if the macula dries faster or remains dry, it is going to end up with, that eye is going to end up with much better vision than if it had any disease activity defined by intraretinal or subretinal fluid. So before 2020, we had the other anti-VEGFs, that was ranibizumab, aflibercept, and bevacizumab. But with all of them, there were certain limitations, like the residual or recalcitrant activity in some patients, in which there was recurrence of intraretinal fluid or non-disappearing fluid. And also that these drugs were not sufficiently durable or long-lasting, and there was a need for multiple repeated injections that were constantly adding to the burden of the patient with multiple visits. So I think everybody agrees that these should be the qualities of an ideal anti-VEGF, and it remains to be seen now whether brolucizumab really has succeeded on all these counts. So with the introduction of brolucizumab, which was, arguably the most clinically advanced molecule, simply because it has the smallest size, and therefore from the antibody fragment, you have this minimal micro-sized molecule, which can therefore be packed into the same volume. This is called molar dose. So the molar dose of brolucizumab is much higher than any of the other anti-VEGFs, and therefore this can result in a higher potency within the eye. So as I mentioned earlier, it's the smallest molecule. It has rapid systemic clearance, but effective penetration into the retina and choroid, probably because of its very small size. So Hawk and Harrer, as I mentioned earlier, compared brolucizumab with aflibercept. Without going too much into the nitty-gritty of the studies, the findings were very illuminating. They found that over 50% of brolucizumab patients could be maintained on a 12-weekly, almost a 3-monthly dosing regimen after receiving 3 loading doses. So this was very heartening to see that at the end of 1 year, the patient had received only 6 injections on average in at least half of the patients. Just an illustrative case of one of my patients who I was initially treating with ranibizumab almost on a monthly basis. And the moment I switched over to brolucizumab, which was in March 2021, you can see that the macula is immediately dry and subsequently remains dry for almost 3 months. So it is not just the statistical data, but also anecdotally we find this. The central subfield thickness fluctuations, which we see with aflibercept, which are also seen in the VIEW 1 and VIEW 2 trials, this sawtooth pattern is not seen with brolucizumab, and you can see a significantly thinner, flatter macula at every time point when you treated the patient with brolucizumab versus aflibercept. And there was obviously a reduction in intraretinal and subretinal fluid, which was significantly less when you compared that with brolucizumab at each of these disease activity visits. So the subretinal fluid reduction was very promising, almost half of what you could expect with aflibercept. And another illustrative case of mine, this was persistent intraretinal cysts in a patient who was receiving very intermittent treatment with bevacizumab simply because he could not follow up very frequently. He's an octogenarian and he found it very difficult to come on a monthly basis. And there was always this persistent intraretinal fluid. And then when we switched over to brolucizumab in July, you can see that even 3 months later, the cysts are at a very, very small level and there's a good improvement in near visual acuity. So it does goes to show that the brolucizumab has a superior drying effect compared to anti-VEGFs. And it also dries the sub-RPE fluid, which is very heartening to see because, this is probably a disease activity indicator. And if you can somehow flatten those PEDs, which is not one of our treatment criteria as of now, we may be able to change the course of the disease. So this is another illustrative case showing that. A very important subgroup of patients where I find that we've really changed our disease management is PCV. And what has changed is principally the unavailability of PDT, which has now led us to move on to anti-VEGF monotherapy. And in PCV patients, we have got excellent results with brolucizumab. This is a post-hoc analysis of PCV patients in the HAWK trial. And here you can see that they had excellent change in the visual acuity from baseline up to week 96 for PCV patients, and also a very large proportion of patients maintained on a 12-weekly dosing regimen after the loading doses. And again, superior drying of the retina compared to aflibercept. So in conclusion, I would like to say that brolucizumab has given us a molecule which has better fluid resolution, faster fluid resolution. Patients also perceive a visual benefit much earlier on in the course of the treatment. It has a more durable effect, at least for 10 to 12 weeks. 10 weeks plus or minus 2 weeks seems to be the median requirement as per the Braille study, which is an Indian study with the real world scenario. Better compliance of patients because of longer treatment intervals, and also the economic factor, which is very favorable compared to other molecules. And it has an excellent effect on variants like PCV. So I'll end over there very quickly, and I'd be happy to take any questions if there are any, either now or towards the end.
Devendra, excellent presentation. Can you hear me?
Yes, Swapnish. Thank you so much.
Yeah. So while you're out there, could you share your experience in non-AMD cases like diabetic macular edema? You must have tried.
No, I haven't. I know people have, but as of now, brolucizumab is approved only for NAMD and PCV. We're waiting for their approval for DME and vascular occlusions. So I so far have not tried it. I've not even tried it in non-AMD CNVM. I know a lot of people who have, and I can say that they have had excellent results as well.
No, great presentation.
Thanks so much.
Fantastic, Devendra. So I was going to ask you the same, but then you've answered that. Now, what about your practice protocol now? When you have the treatment-naive patients, do you offer them pralicizumab right on to begin with, or do you still prefer going the trial and tested the method of offering them ranibizumab first?
That's an excellent question, Piyush. Actually, when I started using brolucizumab more than a year ago, I found that I would be safest if I followed the Hawk and Harrier trials. And those were all done in treatment naive eyes. So all of my initial patients were treatment naive. In fact, the examples I showed you, the first one which I showed you was actually the other eye, fellow eye, was a treatment naive patient in which I had initiated brolucizumab. So now, after that, I've started using it in recalcitrant patients as well. But I have used it in both subsets of patients with very good results.
Fantastic, fantastic. Any other questions that anybody has? For Dr. Devendra? Okay, so then we'll move on to the next talk. Is Dr. Dharmesh?
Yeah.
There? Dr. Dharmesh, sir?
Yeah.
Dr. Dharmesh, like we all know, is a fantastic vitreoretinal surgeon practicing in Bombay, a very high volume surgeon, and he'll be speaking on biosimilar ranibizumab, his experience.
Yeah. Good afternoon. Hi, Piyush. Thanks. Slides are visible?
Visible, sir. And
yeah. As we know, the biosimilars are there in the market since long, and we are all using it since quite a long time, and there are newer things are coming in the market. So what are the biosimilars? Are the near identical copies of the innovator biologic or reference product which do not have significant difference in terms of efficacy or safety in clinical use. And they have the potential to reduce the cost of treatment up to 30% without compromising on dosing interval or the safety. Now here I'll just present the phase 3 study of the efficacy and safety of C plus biosimilar ranibizumab versus innovator ranibizumab, that is Lucentis, for a patient with the wet ARMDs. Now it was a prospective multi-center randomized double-blind 2-arm parallel group active control comparative clinical study was done, and it was done to evaluate the efficacy and safety of biosimilar ranibizumab. And it was a period from July 2018 to November 19, and it was done across the 16 centers in the India. So these are the list of centers all over the India. There are many cities, and the famous retinal practices has taken part. And the study objective was to compare the efficacy of intravitreal injection of ranibizumab biosimilar compared to Lucentis in preventing vision loss, as determined by the proportion of patients who lost fewer than 15 letters in visual acuity in ETDRS chart at 16 weeks compared to the baseline. And secondary objective was to evaluate other efficacy parameters, immunogenicity, safety, and tolerability of the ranibizumab biosimilar up to 24 weeks. Methodologies: the number of subjects they were total enrolled for biosimilar ranibizumab was 106, and in Lucentis group there were 53 subjects. Dosing was biosimilar 0.5 milligram or Lucentis given once every 4 weeks, and the treatment period was 24 weeks. Initially, it was a double-blind period for 16 weeks, followed by open-label phase till 24 weeks. Now, inclusion criteria was an active primary or recurrent subfoveal lesion with classical occult CNVM secondary to ARMD, male or female patients more than or equal to 50 years, and best corrected visual acuity as per the ETDRS is 20/40 or 23/20, Snellen equivalent in the study eye. Now, exclusion criteria is the who has taken the PDT treatment 6 months within or non-study eye in 1 week prior to randomization, previous external beam radiation therapy, TTT or subfoveal focal lasers, or laser photocoagulation for juxtafoveal, extrafoveal in the study eye within 1 month prior. And there was any intraocular surgeries including cataract within 2 months or concurrent any other ocular condition which requires surgical intervention, or uncontrolled glaucoma patients were excluded from the studies. Even patient with idiopathic autoimmune or uveitis, any conjunctivitis, keratitis, any other scleritis or endophthalmitis, or history of diabetic mellitus or diabetic retinopathy were excluded from the study. Now the results in the primary outcome, the ranibizumab biosimilar has a comparable efficacy profile when compared with the innovator, which was innovator was 100%, this was 98.11%, and the p-value was not significant. Both at 16 and 24 weeks. Now for secondary outcome, the comparable efficacy profile when compared with the innovator, so both at the 16 and 24 weeks, it is comparable where the p-value is 0.38 and 0.161. So proportion of patients will be at least 15 letters in the visual acuity. Now when we compare at day 1, day 16, day 24 of the biosimilar and compare it with the original molecule Lucentis, the visual difference in the mean number of letter gain from baseline to week 16 or 24 was statistically not significant between the two treatment arms. And when we compare at 16 and 24 week, the efficacy in the secondary outcome where the visual equivalent is 20/40 or better. So these are the number of patients who have improved in the vision. Now proportion of patients with the visual acuity equivalent to 20/200 or worse, they have been also comparable as compared to the original molecule. And the change in the central macular thickness assessed on the OCT at both 16 and 24 weeks are comparable with the original molecule. And the safety assessment, safety profile is in biosimilar and innovator, both are the same, where adverse events are noted in 26 or 12 patients, and only one patient in the study has been noted death of the patient, but it can be due to ischemic heart disease from previous 3 years, and they have casualty is unlikely related to the study drug, or no other serious adverse events has been reported. An immunogenicity assessment, all the sample analyzed in the study were negative for anti-ranibizumab biosimilar ranibizumab antibody or anti-Lucentis antibodies, or no apparent immunological mediated safety or efficacy reported in the study. So in a conclusion, ranibizumab is comparable efficacy profile compared to the innovator. Adverse events was comparable between two treatment arms. The safety profile during the study in line with known safety profile of ranibizumab, and immunogenicity is there. Just show you the few case studies. This case one is presented with the diminished vision in metamorphosia. Right eye 660, left eye 618, right eye macular scar, left eye was wet AMD. This is the first and the second after first injection. After second injection and after third injection, patient improve up to 6/9 with the reduction in the metamorphosia. Case 2 is the BRVO where we have given, and this is pre-injection and post-injection OCT. Case 3 is the old BRVO already treated, develop again BRVO in the same eye, and we have given injection and the improvement is dramatically seen on the OCT. Case 4 was a treatment naive PDR patient with a cataract and DME, and they have given for both the eyes DME with 3-meter vision after cataract laser and bilateral injections. The vision they have improved to 6/9. Sure. Thank you very much. So any questions I'll take now.
Thank you, Dr. Dharmesh, for the fantastic presentation. Any questions that anybody would like to throw at Dr. Kar? So maybe we can take some questions later on, sir, if somebody does have any questions.
Yeah, sure.
Right now we move on to the next topic, which is OCT biomarkers in diabetic retinopathy. And may I invite a surgeon from the Orange City, Nagpur, Dr. Sarang, are you there?
Yeah. Swapnesh, yeah, good afternoon.
That's me, Piyush. So my
Yeah,
video is
Piyush,
off.
sorry.
No worries, sir. So we can see your
Yeah,
screen.
Sharang.
We'll
Okay. So am I audible?
Yes,
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 we
yes,
can see
Sharang.
your
you're
slides
audible.
Great,
and
great. So good to see a lot of familiar faces after a long time. And I would like to thank the Maharashtra Ophthalmological Society Scientific Committee for having me over here. And it's a fantastic afternoon. I hope you have enjoyed the previous presentations, and I'll take you through some biomarkers in diabetic retinopathy. So nowadays, biomarkers are taking up an uh, important place in analyzing what's happening to the eye and especially to the retina, and they can be evaluated as an indicator of a normal biological process, a pathogenetic process, or a pharmacological response to a therapeutic intervention. And they are important in detecting and monitoring a disease, identifying a patient's most at risk or progression, predict prognosis, explain residual risk, explain how the drugs work, predict response to treatment, monitor safety of treatment, and many more kinds of such important aspects where we would like to know what's happening to these to these patients and what's the response. So there are numerous biomarkers, mainly clinical, which can be general or ocular, or biomechanical and molecular. We would be focusing more so on OCT related biomarkers in diabetic retinopathy, and moving on to retinal thickness. So we all know that it's a very important way to assess a retina by knowing its thickness, how thicker it is, and there have been various parameters. Most commonly being used is the central subfield thickness, and it tells you an overall what's happening to the retina, how thick it is. And but it's very important to note that whenever the thickness goes beyond the stretching capability of the retina, then it can lead to significant damage to the bipolar cells, and eventually leading to decreased signal transmission and eventually having an impact on vision. But many a times these cases do not gain optimal vision post resolution, and that's why it's not so important to assess the thickness of the retina, but to know more about the morphology of the retina. And uh, it's not a very reliable parameter of assessing a vision of a patient. So it's very important that you should focus more on the pattern of the diabetic macular edema, extent of the involvement, and differential involvement, especially if the inner and outer, whether it's involving the inner or the outer retinal tissue. And it is mentioned that cross-sectional area of the retinal tissue between the plexiform layers in CME is a better predictor of visual acuity than the macular thickness itself. So this is how a typical macular thickness map what we get, and we can easily know what's the volume change, and it helps in overall knowing whether the patient is responding or not. But many times the correlation with the visual acuity is not so good. Going to the intraretinal cystoid spaces, so now we are trying to focus more on the morphology, and intraretinal cystoid spaces, as you can see over here, can cause photoreceptor damage, especially if they are located in the outer nuclear layer. And mainly the larger cysts, which are more than 200 microns, we are seen in the late stages of DME and have a significant impact on macular function. And it has been noted that treatment with anti-VEGF therapy leads to decrease in the number and size of these outer nuclear layer cysts. So it's an important biomarker which tells us what's going to happen to the patient. Another important biomarker is presence of hyperreflective signals within the cyst, and which is associated with severe disruption of the blood retinal barrier, as you can visualize in these photographs. And it has been studied by Kashani and colleagues that these kind of intraretinal hyperreflective signals are called as suspended scattering particles in motion, especially on the octa, which is gaining a lot of interest, especially in analyzing these vascular disorders. And this is an extravascular signal on octa, which is due to Brownian motion of the particles, and mainly seen at vascular and avascular junctions. And it has been found that anti-VEGF agents do not seem to directly change their natural course. So this also tells you that probably this patient is not going to do so well. This is a clinical example. This was a 55-year-old male, known diabetic since 22 years, visual acuity at presentation 6/12, and we gave him anti-VEGF injection with a steroid combination. you can note that there is a significant cystoid involvement, and which is reaching up to the outer nuclear layers, and probably this is not going to do well for the patient. And you can see that there is a fair enough control of the edema, but the visual acuity improvement is not so good. So we all can know that probably these cysts which are having hyperreflective foci within are not going to lead to a good visual acuity outcome. Coming to a subfoveal neurosensory detachment, which is also an important biomarker, especially in AMD cases, and also it has been found that it overall has a good prognosis if you have subsensory neurosensory detachment, both in AMD as well as in diabetic macular edema. And almost to the extent of 30% of patients can have this. And more often this is linked to the albumin disturbance in the blood, and that has a significant direct impact on the presence of a neurosensory detachment. But it, as I've said, that it has been associated with good anatomical and functional gains. And it has been found that the steroid implants or use of steroids in such cases, since they have increased interleukin levels, which is a marker of inflammation, as we have known in COVID, that the steroids do work well in such cases of subfoveal neurosensory detachment. This is an example of a male 56 years of age. You can very well appreciate so many things happening in his macular area, and also he has PDR, presenting visual acuity of 6/18 and 6/24, and he eventually improved with combination of injection steroids and macular laser to 6/6, and that's how having a subsensory fluid, if you see, you know that this patient is going to do well. Have I exceeded the time? Should I continue?
No, sir, please carry on. You have plenty of time.
Yeah, so another important aspect is presence of hard exudate. These are ominous visual signals which we get in, especially in cases of diabetes and even in AMD. And these are specifically hyperreflective spots more than 30 microns, and the reflectivity is almost similar to the RP. This is distinct from the hyperreflective foci, what we see, because the reflectivity is similar to the RNFL layer. And eventually it has been found that probably these hyperreflective foci get eventually evolve into hard exudates. And hard exudates especially are lipoproteinaceous, and they also help in monitoring progression, especially the quantitative measurement of these hard exudates. They do correlate with the lipid levels, and definitely in these cases also intravitreal steroids do have a better role in resolving edema associated with hard exudates. Coming to hyperreflective retinal foci, these are distinct from the hard exudates in a way that the hard exudates will show some back shadowing, but the hyperreflective foci won't show back shadowing. So that's how you differentiate between hyperreflective foci and hard exudates, and they are mostly less than 30 microns, absence of back shadowing, and reflectivity is similar to RNFL, as I have said. And it has been found that after resolution of the subsensory retinal detachment, there have been formation of hyperreflective foci in the subretinal spaces. And it is found that initially they are in the inner retinal layers, and subsequently they migrate towards the outer retinal layers, and many a times they go towards the choroid, where they are called as hyperreflective choroidal foci. And they do decrease after treatment with pharmacotherapy. And again, here also implants do much better role, especially in cases where hyperreflective foci are present. This is a classical example where a patient of 53 years of male came to us 8 years. He was diabetic since 8 years, and he was 6'6" at that time, but he had significant proliferative diabetic retinopathy, some amount of diffuse edema, and we did both eyes anti-VEGF followed by PRP and macular laser. So yeah, he didn't report to us for almost 3 years, and that's what we got at the end of 3 years post-treatment, that his vision dropped down to 6/60, and you can very well appreciate that there is presence of hard exudates at the fovea. There are multiple hyperreflective foci. There is presence of an ERM and a taut posterior hyaloid, and we had to subject the patient to vitrectomy. And you can see the contour has come up very well post vitrectomy, but the visual acuity improvement is not so good, because the hard exudates present at the fovea they have destroyed the photoreceptors. So it's a poor prognostic factor, especially if the hard exudate are present under the fovea. Coming to disorganization of retinal inner layers, so this is a very important entity which has been explained, especially in diabetic maculopathy, that drill lesion, and it has been seen that in the central 1 mm zone, if the drill lesion is more than 50%, then these patients don't have a good visual prognosis. And recent studies have correlated that the amount of maculopathy, the macular capillary non-perfusion, and severity of diabetic retinopathy do have a direct correlation with the drill lesions. So this is an example of a drill lesion. You can see that the inner layers of the retina are indistinguishable, and these patients do have less vision at presentation. Many times, whenever the macular edema resolves, eventually a drill lesion appears. So these patients, if the drill lesion is very close to the fovea, they have a significant impact on vision. Coming to another biomarker is a bridging retinal process, where it has been seen that these processes, they are constituted by the Mueller's and bipolar cells, and they do have a good prognosis. So this is an example of a 53-year-old female. She was diabetic since 10 years, and you can see these bridging retinal processes, these arrows, and we did anti-VEGF therapy followed by laser. So mainly in diabetes, you require all sorts of combination of treatments, and these patients did very well, and she improved to almost 6/6 with this kind of combination of treatment. So probably this bridging retinal process must have an impact on the final visual acuity, as has been described in the literature. Another important factor is the photoreceptor outer segment length, and it has been shown that it has a direct correlation.
Sorry to interrupt.
Yeah, please.
Can we just rush through, sir? Now we have just one more presentation remaining.
Yeah. So should I sum up?
Yes, sir, it would be nice if you can.
Yeah, sure. So the integrity of the ELM and EZ is an important factor. And again, torque posterior hyaloid, as we all know, that this is a case, these cases do respond very well to vitrectomy. Another very important choroidal biomarkers, so hyperreflective foci, choroidal thickness, and choroidal vascularity index, they do have an impact on the morphology of diabetes and the response. So thank you very much, all of you, for patient listening. Thank you, Piyush. Thank you, Swapnesh and Ragini madam, for having me over.
Thank you, Dr. Sarang, for taking us to all these biomarkers. It's so important to know about them and just incorporate our understanding within our practice so that we can prognosticate to patients as well. So with this, we quickly move on. We won't have any time for questions. So we move on to the next topic, which is quite interesting. It's by Dr. Sneha Saurabha, and the title of the talk is Patch by the Side. I'm quite intrigued to know more about this. Madam, are you there?
Yes, sir. Can you hear? Is it audible?
I can hear you. If you can share your screen, please.
Are my slides visible?
Yes, ma'am. Please do go ahead.
Okay. Very good afternoon to everybody. I would like to thank Maharashtra Ophthalmic Society organizers and the scientific committee for giving me this opportunity. I'll be presenting 2 short cases of the same topic. The first case is a 77-year male presenting with right eye blurring of vision for 15 days, which was sudden in onset, painless, and non-progressive. He was a known hypertensive, diabetic, and he had a history of CVA 3 years back. His best corrected visual acuity was 6/12 in both eyes. Anterior segment showed senile immature cataract. On dilated fundus examination, the media was clear in the right eye. Disc and retinal vasculature were normal. There was a dull yellow deep lesion. There was a dull yellow deep lesion of about half disc diameter.
Your slides are not visible.
Not able to see the slides.
Just to enlarge it and move the slides.
Okay. Now, sir?
Now visible.
Okay. The media of the right eye was clear. There was a dull yellow deep lesion of about half this diameter with irregular margins superotemporal to the fovea, like a patch by the side of the normal fovea. Rest of the fundus was within normal limit. Autofluorescence showed no corresponding abnormality. The right eye media was clear and the left eye media was clear, and the fundus showed only ERM, no other abnormality. The OCT of the right eye along the macula, along the horizontal meridian was normal, but the sections along the lesion revealed a hyperreflective band in the middle layers of the retina, including the outer plexiform, inner nuclear, and the inner plexiform layer with normal fovea. OCT of the left eye was normal except ERM, epiretinal membrane. Case 2 is a 71-year male presenting with blurring of vision of right eye for 2 days. He was diagnosed to be hypertensive 1 month back. His best corrected visual acuity was 636 parts in the right eye, and left eye was normal. Anterior segment was within normal limits. Right eye, the fundus showed hyperemic disc with dilated tortuous venues with multiple retinal hemorrhages in all the quadrants with dull FR. Left eye was normal. The right eye OCT revealed small SSRD, that is subfoveal serous retinal detachment, with hyperreflective material in the center with minimal intraretinal fluid. Patient's BP left eye OCT was normal. Patients from the history and the clinical picture, we diagnosed him to have ischemic CRVO, non-ischemic CRVO with macular edema. But his BP was 210 by 110. And further investigating, his serum homocysteine was raised. So we started him on treatment for the same, that is tablet homocheck and antihypertensives, collaborating with the physician. As the SSRD was very minimal and his BP was raised, we decided to observe him, controlling his systemic factors. After 3 weeks, his vision remained 636 in spite of the OCT showing resolution of the subretinal fluid. Here there shows irregular hyperreflective lesions in the middle layers of the retina. So this accounted for the low vision, which is actually termed as PAM. PAM is paracentral acute middle maculopathy. It is basically an OCT-based finding seen in the retina, manifesting as hyperreflective band in the middle layers of the retina, that is outer plexiform or inner nuclear layer, which is seen in SD-OCT or above OCTs. It was first reported in 2013 by Sara et al. Initially, it was considered as a variant of AMN, that is acute macular neuroretinopathy. But AMN is seen more commonly in younger, and it has a more female preponderance. And the OCT shows involvement of outer retinal layers as well. In PAM, the basic pathology is the ischemia of the deep retinal plexus. So mostly they are seen in older age group and they present as acute scotoma. How to differentiate it from cottonwool spots? The PAM lesions are more deeper, they are more dull, they are less opaque, and they do not follow the retinal nerve fiber layers. PAM can be primary or secondary. The first case here, which I presented, was a primary where there were no other ocular abnormalities, and the second case was secondary to venous occlusion. Coming to the management, there is no active intervention that is required or available as well. We investigate for the ischemic event and treat for the same, collaborating with the physician. What is the prognosis? The lesion may self-resolve completely, but generally they cause focal retinal atrophy leading to permanent scotoma. Take-home message is not all hypopigmented lesions are cottonwool spots. PAM does give answers to certain unexplained visual losses in cases of venous occlusions or certain surprises after cataract surgery. PAM has no active intervention. Advancement in technology helps in better diagnosis. That is, PAM was detected only after SD-OCT was developed. So embrace the new technology. These are my few references. Thank you very much. Thank you once again for the opportunity.
Thank you very much, madam, for the wonderful presentation. And we just shy of a minute for the session to be over. So I'd like to thank all the speakers for finishing in time, and the chair and the co-chair as well.